Hi there, Joseph. Dr. Llovet, thank you very much for joining me today as we discuss a recent publication, the LEAP-002 study, which evaluated in a frontline setting in advanced liver cancer, Child-Pugh patients, Lenvatinib and Pembrolizumab versus Lenvatinib and placebo. And the primary endpoint for this study was to improve overall survival in patients with advanced liver cancer. Can you go into a little more background on the study and the study design or selection criteria, a little more detail?
Yeah, well, hi, Richard. So this is the classical trial in frontline advanced HCC, where generally the majority of the patients are with advanced disease, meaning portal vein invasion, lymph node involvement, or metastasis, or ECOG 0-1. There is a percentage of patients, around 20% of the patients, that are at the intermediate stage that progress to local regional therapies. So the trial was randomized 1-to-1 to receive Pembrolizumab during 3 weeks, as you know, plus Lenvatinib according to the body weight, 8 or 12 milligrams, compared to Lenvatinib versus placebo in a double-blind, double-limit fashion, and stratified for the classical stratification factors, high FP, geographical region, ECOG, and so on and so forth. In summary, in a nutshell, the results are Lenva plus Pembro actually show a very good outcome, I would say, 21.2-month median survival. But what was striking in this trial is the median survival of Lenvatinib alone, 19 months. And this one completely unexpected, as you know, in REFLECT was around 13 plus months. And as a result of that, despite that there was a non-significant trend, the trial that has 2 co-primary endpoints, overall survival and progression-free survival, so the alpha was a split, p-value was 0.023 and was negative.
So a disappointing study for all of us, I think, because the phase 1b that drove this study, looking at this TKI with PD-1 inhibition, looked very promising. And when we look at the results of LEAP-002, they don't look too much different, right? The objective response rate was quite high. Survival was very similar to what we saw, over 20 months. But it was still negative because of some of the statistics. We also did not include patients with main portal vein invasion, something that some studies have. So would you design this study differently, looking backwards?
Well, yeah, as you mentioned, so I think what are the reasons for this negative trial? I think that the trial was, the combination is good, but is this type of trials in which you have a good result, but not positive. So the reasons are threefold on my mind. The first one is the control arm. So all the trials in frontline have been randomized to sorafenib. And sorafenib, despite accepted first-line therapy, has a ceiling of 15.5 months median survival in 11 trials. And it's not moving from here. With Lenva, we have 19 months. So this was the first reason, I would say, that the competitor was very good. The second is that the alpha was split. So if you see this trial, you see the hazard ratio, p-value 0.023, 2.2-month difference in survival. You said, okay, it's positive. And the trial was negative because of the split of the alpha to progression-free and overall survival. So I would not do that in my mind in further trials. I will stick to OS. The third thing, and the reason why Lenvatinib had 19 months is because the time of exposure was 9 months. And this is because the physicians get used to deal with Lenvatinib, as opposed in the REFLECT trial, that was the first time that in HCC this drug was used. So I would say these are the main reasons. There are other reasons about vascular invasion, slightly differences with REFLECT. Eventually, the population of this trial is slightly better, but I would say that the main reasons are those that I mentioned.